It's just a little slow.
All right. Fairly typical 85-year-old male involved in a motor vehicle collision. Not awake, does not open his eyes under any circumstances. He withdraws from pain, does not make any verbal attempt. And so DCS of 6. And are you guys familiar with that nomenclature, E1, B1, M4?
Highest verbal motor.
Exactly. And so that's actually much more useful for us. I mean, guys, you tell me your GCS is 6, but if you say E1, V1, M4, I'm like, oh, okay, now I know exactly what he's doing. So, highest verbal motor. You don't have to, but that's just kind of a standard way that we communicate a little more information. So now, when we talk about any kind of neurodeficit, we've got to divide this into, is this a focal deficit or is this a generalized? So a focal neurologic deficit, you can localize it to one single place. If this light bulb is out, that's the focal. You know, the rest of the building has lights, it's out right here. So then we go looking at the light switch, we go look at the wiring there, we don't go looking for the power company. That's a focal deficit. And the whole point is it can be localized to a single anatomic site. It can be anywhere, but it still goes to a single site. The next thing when we talk about these things are upper motor neuron and lower motor neuron. Now this gets a little bit complicated here, but this is going to help you try to determine what's going on, whether this is going to be the beginnings of a herniation syndrome or whether this is somebody who just got their nerve cut. So when we talk about an upper motor neuron lesion, this is when the brain doesn't work anymore. And it presents with what's called a spastic paralysis. And so you ask someone to move their hand and they can't, but if you test the reflexes, they're going to be just exaggerated. Because one of the things that the brain does is mediates the reflex response. That's what keeps you from, you know, if you touch your knee, the patella tendon, that's what keeps it from really, really kicking really hard, is because the brain sort of damps down on that reflex. If the brain is taken out of the picture, then all that's left is the reflex, and you get this really, really just really strong reflex. But they can't move it. So the reflexes are intact, but they can't move it. That's a spastic paralysis. That tells you that something happened up here. Another term is focal brain dysfunction versus diffuse. Focal brain dysfunction, you guys are very familiar with. That's your very classic stroke. They can't move the left side, the right side's still working. Does that make sense? And the other thing, though, is diffuse bilateral. And so this is when the whole brain is affected. You guys are probably familiar with this, with the effects of alcohol. But anything, if enough of the brain is damaged, we actually end up with both sides getting damaged. That's where we start to see confusion and altered level of consciousness. So if it's a focal, it usually does not cause confusion. Even for our strokes in which the folks can't understand, that's just because they've taken out the language centers. They can still follow commands, they can still do the other things. Focal deficits, like a single stroke, usually don't cause confusion. When the whole brain is damaged, that's when we have problems with confusion and altered level of consciousness. Any questions on that? Again, these are just, so when you assess somebody, if they say they can't move the right leg, and then you test the reflexes, and they're really hyperactive, that tells you that the signal's not getting from the brain to the leg. That makes sense? If you test the reflexes and the reflexes don't do anything, that means the nerve to the leg is cut. Make sense? Again, because the goal here is to differentiate whether this is a nerve injury or whether we're about plaque. So lower motor neuron, again, this is the nerve. And so it affects the nerve fibers traveling from the spinal cord to the muscle. And this is a flaccid paralysis. Just like I said, you ask them to move it, they say, I can't. And then if you test the reflexes, it doesn't move. So it's a brain problem if they have or at least a very high spinal cord, of course. If they have really very, very brisk reflexes, but they can't move it. It's a nerve problem, meaning the wiring that goes to the leg, if They can't move it, but it also does not have a reflex. So, trauma patient with extra brisk reflexes to the lower extremities, but he cannot move them voluntarily. Which one is this?
Brain.
Brain upper. Yeah, absolutely. Fractured humerus. No reflexes at the wrist and no voluntary movement. What's this? Lower, exactly. So somewhere in the nerve going to the thing. Expressive aphasia, but still able to follow commands and perform tasks.
Are you asking me that as a question?
Yeah, which one is it?
That would be the upper.
It is a focal upper, exactly. Because it's not the whole brain that's affected, because he can still perform tasks and follow commands. But something in there is not working. So this is a focal stroke. Focus area, of course, is the speech area of the brain.
It's just
All right.
They want to see that.
He's reading off of it. He texted me. I know what he said, but I can't switch back and forth. They'll get dizzy.
All right. So next,
I know.
we got to discuss the ways in which you can have altered mental status. And so in trauma, of course, maybe beforehand they were doing drugs. That's fine. That happens. Periodically, people get drunk and do stupid things. But we can also get altered mental status, not just from the brain injury, but from other things. The most common cause of altered mental status in trauma is actually going to be one of your hypoperfusion syndromes. You don't get enough blood going to the brain, you're going to have altered level of consciousness. This isn't a brain injury, this is a circulatory issue. So we have to make sure that we correct that before we go hunting down, hey, do we have a brain injury here? You can, of course, have direct injury to a portion of the central nervous system. If you have an axe to the head, that's a pretty good reason that they have altered mental status. And then, of course, cerebral edema, which occurs because of blunt trauma to the brain. And that's going to be, of course, what we're talking about today. So again, hypoperfusion of the brain. So you guys have all seen this. Mild hypoperfusion is otherwise when they just, someone who's dehydrated and blacks out. Moderate hypoperfusion, sweat excessively, pale, nausea, feel like vomiting. And then prolonged is when you're going to have loss of consciousness, cerebral hypoxia, and actually death of the brain tissue. So again, whenever we see a trauma patient with an altered mental status, we have to make sure that we're actually perfusing the brain first. That's key. That actually does more damage than anything else, is if we don't give adequate blood to the brain. Now go, again, chasing down some of these treatments. Go back to your basics first. And then, of course, your physical exam is going to give you clues to that. Audible bleeding. What's audible bleeding? They're bleeding too much, you can hear it hit the floor. So, large pools of blood, expanding hematomas, a bruise that was this big, and now it's this big, particularly in like a leg. Rapid heart rate, low blood pressure, pale, cool skin, lower body temperature. All right, any questions on that? So we have to have a good, clear idea in our brain. What is the reason that this person has a problem? Did they cut the nerve? How do we know they cut the nerve? Because they don't have reflexes. Is it something up here in the brain? Or they have altered mental status because they did drugs? Is it because we don't have enough perfusion? And finally, once we go through all that, we're like, okay, we've got adequate perfusion. This is an upper motor neuron lesion because they have very brisk reflexes. Then we can move on. So, the basis of herniation syndromes is the Monroe-Kelly hypothesis. And it's, somebody just stuck their name on it. I mean, we know this. The skull is a fixed area. 80% is taken up by the brain, and then you got blood and CSF. The skull doesn't expand. So if something gets bigger inside the head, mass, tumor, whatever, something else has got to. Something has to go out, CSF or the brain. It's not anything complicated here. You got a mass that's getting bigger. You got bleeding that's getting bigger, whatever. So you got to squeeze something out. Now, a lot of people get this. This is sort of the basis of not treating elevated blood pressures with brain injury. And we're going to get some of the math here. But the brain needs 50 mLs of blood per minute per 100 grams of tissue. The way that we get blood to the brain is to overcome the pressure in the skull. When we so far, you got 100 millimeters of mercury pressure inside the brain. No blood's going to go in there until you get above 100 millimeters of mercury. That makes sense? And so again, mean arterial pressure has to be higher than the intracranial pressure. Otherwise, no blood goes to the brain. And that is called the cerebral perfusion pressure. And so, and it's the difference between how much your blood pressure is, your MAP, over how much pressure is inside the skull. And again, you see, usually that's 80 to 100 because usually there's very little pressure inside the skull. Any kind of increases in ICP, and you really decrease the amount of blood that the brain gets. So again, mean arterial pressure is what pushes blood in there. The resistance, of course, is the intracranial pressure, which is usually nothing.
Can you measure that?
Yes, but not in the field.
Okay.
You quite literally stick a tire gauge into the ventricle. So. But and again, this is, and we'll see later on how they did measure intracerebral pressure after these interventions that we're talking about. And so, if the difference between MAP and ICP is less than 50, then you start having tissue die. If it drops less than 30, then it goes to brain death. And so this is why we try not to drop blood pressure in anything that's going to have cerebral edema, because that's going to prevent blood going into the brain. The brain does try to regulate, so it can change how much blood goes to it by dilating the blood vessels. It can displace around 100 mLs of CSF. And then after that, we get Cushing's triad and eventually some nastiness. Cushing's triad, of course, is flattened pulse pressure, bradycardia, increased systolic blood pressure, and irregular respirations. We start seeing some of these nasty things, blown pupils, pinpoint pupils. But again, don't just hang your hat on that, because certain eye drops, general anesthesia, those can also cause blown pupils. And then pinpoint pupils, of course, frequently caused by medications. Anisortia, this is when you have your different size pupils. Sometimes it's actually a normal variant. Addie's pupil is a very common situation that occurs, particularly in females. And it's just exactly what it sounds like when people look big and the other looks different. But of course, it's also associated with compression of cranial nerve 3 due to the brain trying to shift. And sometimes you can have really weird looking pupils after surgery, but at the same time, you can end up seeing it with ischemia. So this drives you crazy. It's always handy if we can get some kind of history. You know, hey, did we have irregular pupils before? But again, these are some of the signs. So again, brain herniation. You got blood going into it. It's a fixed space. What are you gonna do? You gotta squeeze the brain somewhere. So where does it go? Side to side, side to bottom, top to bottom, bottom to top, or out the dome. These are here. There's no point in trying to memorize it. These are just some of the common signs that shows that you're about to herniate your brain, and they're generally all associated with somnolence and coma. They usually all have some kind of pupillary deficit. Sometimes they have posturing. But again, so any questions on that? So now, what can we do about it? All right. So when we have a brain injury, 2-hit hypothesis. The first hit is that's, something struck the brain. We can't fix it. Neurosurgeons can't fix it. You already damaged the brain. Where we intervene is the second hit. And so this is most commonly as a result of systemic hypoxia or CNS blood flow. And this is where we can intervene. Three things we have to avoid: hypoxemia, hypotension, and hyperventilation. Hypoxia is going to be very common. The problem here is that somnolence is associated with almost all of these, including a decreased respiratory drive. And so we will frequently, as soon as we come upon a patient, have a low oxygen saturation. So we try to just make sure that we maintain adequate oxygenation as early. And if there's even a single O2 sat less than 90, we double the mortality. And one study said we triple it. And this is just from a moment's inattention of moving the patient, not bagging. If their sats drop, then we suddenly double our mortality. So we have to avoid hypoxemia. But hyperventilation is worse. It's actually up to 6-fold increase in mortality if we bag them too much. So how does that work? What keeps blood vessels open is CO2. And so if we blow off all of our CO2, the blood vessels going to the brain, they tighten down. And so you get less blood going to the brain, which of course makes things much, much worse. And so, true, it does lower ICP because we're getting less blood to the brain, but we're getting less blood to the brain. The brain needs it. And so this is where ITLS guidelines show end-tidal CO2 with a target of 40 with a range of 35 to 45. That's how you maintain optimal flow. You familiar with that? No hyperventilation, no hypoventilation. Hyperventilation is actually slightly worse than hypoventilation. And hypotension, again, this is what we said before. A single episode of less than 90, it's a doubling of mortality. And if it happens more than once, 800% increase in death. So again, this all goes back to ABCs. But now, because we know we're going to watch our end-tidal CO2, we're going to make sure that we're adequately perfusion. We're going to stop any ongoing blood losses. We're going to make sure we keep them warm, of course. And now, we're going to talk about what we can do. So, Monroe-Kelly hypothesis. Perfusion pressure is not adequate. We're not going to get enough blood to the brain. So we have to either make the skull bigger. We can't quite do that in the field yet. So we have to make something smaller. So the only thing that we can do is shrink the brain. What happens if you pour salt on a slug? Exactly, it pulls all the water out of it. So this is what we're going to do. We're going to make the brain smaller by pulling the water out of the brain. Once the brain is smaller, then we have less pressure inside, and then we make sure that we can keep more blood going to the brain. So if we surround the brain with a salt or sugar solution, it's going to cause it to shrink. And this decreases ICP, increasing cerebral blood flow. And then over there, you can actually see, you asked earlier about pressure in the brain. And so these are intracranial pressure monitors. And then they show the time after administration of either salt or hypertonic saline or bicarb. That makes sense? All right. Now the obvious question, why not hypertonic saline? We already have a 6% salt solution. Sodium bicarb is a 6% salt solution. It's just they use CO3 rather than Cl. As far as the sodium content, it's still 6%. Now, why do we not carry mannitol? Because it crystallizes. It's horrible to try to deep into any kind of solution. It even gets cold, it does that. So, 100 mLs given over 20 to 30 minutes. And that you basically given 100 cc's of 6% saline. That is going to cause water to go out of the brain. That's going to increase the cerebral perfusion pressure. You may get a transient rise in end-tidal CO2. Bicarb is CO2 for all intents and purposes. And so very briefly, you may see the end-tidal CO2 go up, so stay in range. And then again, don't forget hypotension and perfusion. Questions?
You said that, what about you said sugar solution?
Mm-hmm. Yeah, there's nothing wrong with it. It's just, it's difficult to store, and you guys already have hypertonic saline. It's just not called that.
So you said there'd be a transient rise in end-tidal CO2 if possible.
From what I read, sugar actually
when it goes through the rest of your body, it pulls water off, which can lead to hypotension.
And that
You know,
doesn't
just like a
happen.
diabetic that, you know, urinates to try and get their sugar down.
When you're giving Bicarb, are you just mix that in the bag and do, or is that just a slow push?
You guys will have to decide that. I mean, the studies that I saw were just give a little bit, and do something, give a little bit, and do something. But I mean, so,
I didn't know like if that just had to be a drip or if you just had to be a constant slow push or.
I mean, it's whatever you can
To
do.
me,
arrange
we've
on the
got-
truck, so.
100 milliliter bags now. You know, if you had the time to
There you go.
push it in there and then just do it as an IV drip, I mean, then you don't have to worry about picking it up. But at the same time, it's handy for you to just push a little bit, do something, push a little bit.
I just didn't know
mean,
like if it had to be, just sort of maybe just a slow.